Hi, my name is Gillian Dank, and I'm from the Koret School of Veterinary Medicine at Hebrew University, and I'll be presenting an abstract on non-invasive detection of spontaneous tumors in pets. So as everybody knows, cancer is a huge issue in both dogs and cats all over the world. Currently, cytology and biopsies are our best way of getting a diagnosis. Generally, cytology isn't invasive, but biopsies may be invasive and lead to increased cost to the owners. In most cases, they involve sending the samples to the lab. Knowing whether the mass was benign or malignant in the examination room would be very beneficial. The technology for this system is based on the tissue's response to thermal excitation over a short period of time. Since the physical characteristics of malignant tissue are different from those of normal tissue, the heat diffusivity in malignant and benign tissues differs. Heating the examined area safely leads to a different response in these tissues. So here you can see the system. The tissue is heated to no more than 41 degrees Celsius with the heat source, the LED light. The device is held over the mass for 1 minute while the thermal camera records the heat loss. So here is an example of what the signal looks like. The heat source is turned on, and this is what heat decay looks like over time, over approximately 1 minute. So as we said before, different tissues render different responses to the thermal excitation. The heat decay enables the identification of benign and malignant tissue and for us to be able to differentiate between them. Therefore, it is possible to use the properties of thermal excitation and the behavior of the thermal relaxation to distinguish between normal, which is the blue, and malignant tissues, which is the orange. So as I said before, the tissue is thermally excited by the light radiation, and the camera actively scans and records the data. The thermal signal is recorded and analyzed by HT's AI algorithm to obtain thermal diffusion features. A comparative analysis is carried out between adjacent points of the image, as well as an analysis in reference to a cumulative database obtained from all of the previous examinations. This process yields heat diffusion scores that are correlated to the cluster cancerous probability. The output is presented as a functional heat diffusion map, distinguishing between different areas detected in the examined tissue, indicating cancer. And we'll see an example of that further on. So the first study that was performed was in mice. It included 20 female, 9 to 11-week-old mice. There were 11 mice that were injected with IV with Lewis lung carcinoma and 2 controls. The procedure itself was performed on the excised lungs. There were a total of 60 sites, 2 normal and 1 abnormal sites for each of the 18 injected mice, and 3 normal sites from each of the 2 control mice. And here we can see the results. In the total of 60 mice, 17 were true positive, and 1 was a false positive, 1 was false negative, and 41 were true negative. So, out of the 60 sites from 20 mice, 1 site was false negative, 1 site was false positive, and there was a 97% accuracy that was achieved. These are the diffusion maps that I talked about before. Here we can see the optical image of the lungs. Here we can see the pathology slide, and here we can see the diffusion map, which tells us whether the tissue is supposed to be normal, which is blue, or red. And here you can see that there's correlation between the optical images and the past slide and the red abnormal cancerous tissue. So a clinical trial was performed on oral tumors in people. It was a pilot and feasibility study for the use of the device in people. The goal was to correlate the association of thermal diffusion, either positive or negative, of oral tissues with biopsy outcomes. The study population was 85 adult patients who presented to the oral and maxillofacial departments of surgery with oral lesions that either in the Israel and 2 centers or in the United States that required routine biopsies. 85 subjects examined lesions, and this has been submitted for publication. So based on these promising results in mice and in people, we proposed to do a study in dogs. And our hypothesis was that thermal diffusion in malignant tissue would differ from benign tissue in dogs with external masses. This was a prospective, blinded clinical trial. The study population were dogs that presented to our teaching hospital with external masses in 50 dogs, and the inclusion and exclusion criteria were any dog with external tumor that could be palpated and measured and had a definitive diagnosis of either cytology or biopsy. The primary endpoint was lesion classification by the device, either positive or negative, and all demographics and clinical information was collected. Before starting, we had an ethical approval that was obtained from our institution, and for each dog, the owner signed an owner consent form, and the hair in the area was clipped. The HD bioimaging procedure included the following steps: a system setup and checkup test that was performed without the animal, focusing the system a few centimeters from the tumor, starting to scan, heating the tissue to the desired temperature, and recording the heating and cooling phases using the thermal camera. That scan was repeated 3 times. And here we can see site marking. 2 areas were marked on each image: the suspected area, which was either malignant or benign, and a healthy control area. Here you can see the device. Here you can see that I'm using the device on the dog. You can see the blue LED light heating the area. So we have a total of 48 dogs that were enrolled in the study. 45 dogs were included in our data. 3 animals were excluded, 1 because of insufficient clipping, and 2 because of system failures during the test. So the 45 dogs yielded 69 different masses or lesions. The number of lesions sampled per dog: 22 dogs had 1 lesion, 23 dogs had 2 lesions, and 3 dogs had 3 lesions. So there were 28 malignant cases, 11 were diagnosed by cytology, and 17 were biopsied. There were 41 benign cases, 33 were diagnosed by cytology, and 8 were biopsied. The number and type of benign lesions, for a total of 41, there were 21 lipomas, 4 adenomas, 3 sebaceous adenomas, 2 keratinous cysts, 2 perineal adenomas, 2 epitheliomas, 2 reactive lymph nodes, and 1 of tracheoepithelioma, sebaceous hyperplasia, sebaceous hamartoma, papilloma, and melanocytoma. The types and number of malignant lesions were 10 lymphomas, 5 low-grade mast cell tumors, 2 cutaneous hemangiosarcomas, 2 sarcomas, 2 cases of undifferentiated neoplasia, 2 adenocarcinomas, and 1 of the following: carcinoma, a round cell tumor that was most likely a plasmacytoma, a metastatic lymph node from melanoma, hemangiosarcoma that might have been a metastatic lymph node, and 1 case of osteosarcoma. So these are the results of the full data set of 69 different masses. There were 25 true positives and 36 true negatives. There were 5 false positives and 3 false negatives, giving a sensitivity of 89%, a specificity of 88%, an accuracy of 88%. So 8 of the 69 lesions were misclassified. The false positives included 5 cases, 1 keratinous cyst, 3 lipomas, and 1 sebaceous gland adenoma. There were 3 cases of false negatives, 2 lymphomas, 1 round cell tumor. The round cell tumor was in the mammary area and most likely a plasmacytoma, but it wasn't certain because immunohistochemistry wasn't done. So when looking at the data, we saw that the deeper tumors, including the lymphomas and the lipomas, were more problematic. So we discussed it and we thought that maybe we should do another analysis excluding these cases. So because they were deeper and may require a higher temperature, we asked the mathematicians to reanalyze the data. The cases that were removed were 2 samples with reactive lymph nodes from the benign group, and from the malignant group, 10 samples with lymphoma, 1 case of the metastatic lymph node because of the oral melanoma, and 1 case of a possible metastatic lymph node from hemangiosarcoma. So here are the results from those 55 cases without the lymph nodes, and here we can see the results have changed a little. There are 15 true positives, 38 were benign tumors and diagnosed as benign tumors, with 1 false positive and 1 false negative. So in this case, the sensitivity increased to 94%, the specificity increased to 98%, and the accuracy increased to 96%. So which one was the false positive and which was false case? The false positive was a benign epithelial process of a keratinous cyst, and the false negative was a low-grade mast cell tumor. And this is an example of the results that people will see in the future. Again, we were blinded in our case, so we did not see any results, but this is what it would look like with a probability rate for cancer. So the limitations for our trial are, first of all, the number of cases. The trial was started with the outbreak of COVID-19, which has made case accrual much more challenging. Deeper tissues, we saw that some of the lymphoma cases may be deeper, and the penetration of the light is only 3 millimeters, so we may need to change the heat source configuration, and additional data. We need additional cases of non-malignant lymph nodes for their algorithm training. Our initial results are very promising. Future directions are additional cases in the present study to refine the algorithm, expanding our study into a multi-centric trial. Clinical trials are opening both at Hope Veterinary Hospital and UC Davis, monitoring for local recurrence in dogs with malignant tumors, and staging. This study was funded by HT Bioimaging, and I am a scientific advisory board member for HT Bioimaging. So thank you all for listening. Thank you to everyone at HT Bioimaging and to Michael Kent for his help. And thank you to my family, to my husband and my kids for letting me have the time during the lockdown to have time to work on this. And I'd be happy to entertain any questions. Thank you.